Hello, I am Dr. Rezaul Karim, Registrar, Critical Care Medicine Department, Imperial Hospital, Chittagong. Today, I would like to discuss about oxygenation for COVID-19 patient and post-COVID care. First of all, I want to discuss about a scenario, that is Mr. Jaman, 75 years old, retired diabetic man, come to the emergency department with a history of fever for 7 days associated with cough and breathlessness. After proper history and examination, he found hemodynamically stable, although his tachypneic, and his temperature is 100 degree Fahrenheit. And we suggest him some routine investigation to exclude COVID-19 diseases, and one of the important thing is he is COVID negative, and he did RT-PCR for COVID-19 and found negative result, but his sign symptoms suspected for COVID-19 diseases. So we suggest him some blood profile like CBC, CRP, ferritin, D-dimer, procalcitonin, and an imaging. We offer him HRCT of CT scan to exclude any pulmonary infiltrate. And after investigation, we found that raised D-dimer, raised ferritin, although total count is found normal, but there are granulous opacities in his chest CT scan that involves more than 50%, and we offer him to admit in the hospital, but he refused it, and he want to establish that he's completely well. This is some sorts of runny nose and fever, and this happens every year, but we try to convince him that the blood profile is not good at well, and the imaging report shows there are granulous opacities, and that involves more than 50% of his lungs, but he cannot understand, and his family member also cannot understand these things as well. And then I can convince him to admit in the hospital. After giving admission in COVID unit, duty doctor receive him and then provide him oxygen. So, what is the method of delivering oxygen for this patient? So, after receiving this patient, the doctors check his vitals as well as saturation, that is the oxygen saturation of his blood. What is the oxygen saturation? Oxygen saturation means we can check it through pulse oximeter. If we put a pulse oximeter in our hand, it can give a reading that pulse, and it can give a reading of SpO2 and respiratory SpO2, and also there may be some sorts of dysfunction of this pulse oximeter, and there is pulse and oxygen saturation. The combination of pulse and oxygen saturation is provided in this pulse oximeter, and if the saturation is below 94%, we provide him oxygen. And he found that his saturation is below 90%. That's why we start him oxygenation. So first method of oxygenation is we give him through nasal cannula. How can we provide oxygen through nasal cannula. Okay, this is the flow meter. This is the flow meter, and this is the central line. Through central line, oxygen comes to the flow meter, and there are some calibration mark 0 to 15 in the flow meter, and we can provide up to 15 liters through this flow meter, and we connect a nasal cannula, a simple nasal cannula, to the flow meter, and oxygen comes through the central line, and we put it into the patient through the nose and fix it and give oxygen 1 to 6 liter through this nasal cannula, and check saturation for this patient. If saturation is still below 94%, we have to raise oxygen level. Before that, I want to discuss about nasal cannula. What is the advantage of nasal cannula? The first and most important advantage is I can talk. If I connect through a nasal cannula. I can drink, I can eat if I put a nasal cannula. But if I put a face mask, I cannot talk, I cannot eat. So if the oxygen requirement is below 6 liter, we can provide it through the simple nasal cannula, and this is more convenient. And disadvantage is we cannot give high flow oxygen, and we cannot give more than 6 liter oxygen through it. Okay. Our environment provides 21% of oxygen. That is the fraction of oxygen we inspired. We call it FiO2. FiO2, fraction of inspired oxygen. The fraction of inspired oxygen we take from environment is 21%. And if we take nasal cannula, the added 1 liter add 4% FiO2. So if we connect it and provide 1 liter, that is 21 plus 4, so 25%. So if we rise oxygen up to 6 liter, so 4 into 6, 24, and 21, that is plus 24 plus environmental 21, total 45%. So we can provide up to 45% FiO2, or we can achieve up to 45% FiO2 through the simple nasal cannula for the COVID-19 patient. Okay. If patient cannot tolerate this nasal cannula and the oxygen level up to 6 liter, but his saturation cannot maintain, we give him the simple face masks. The face masks can be simple face masks, or there are different types of face masks in the market that is called Venturi face masks. Venturi masks has some criteria. We can provide oxygen by a metered dose, and we can control oxygenation. This is the simple face mask, and through this face mask we can provide oxygen up to 10 liter, up to 10 to 12 liter. So we fix it to a flow meter, raise oxygen up to 10 liter, and put it like this and give oxygen, and then check again saturation. And if the saturation is still below 94%, if the saturation is still below 94%, we go for another marks that is called non-rebreather marks. What is non-rebreather marks? What is the criteria of non-rebreather marks? This is simple face marks plus a reservoir bag. This is called non-rebreather marks. So, what amount of oxygen can be delivered through non-rebreather marks? Through non-rebreather marks, we can provide 15 liter of oxygen, up to 15 or 16 liter of oxygen. Oh, one thing I forget that if I provide 10 liter oxygen or 12 liter oxygen through the face masks, we simply think about 10 liter oxygen. 10 liter oxygen provide, so environmental 21% plus 10 liter per liter 4% FiO2. FiO2 increase 4% in 1 liter oxygen. So 10 liter, 4 into 10, 40%, and environmental 21%, total 61%. We think about 61 to 65% oxygen can be provided through these face masks. And if patient is still hypoxic, and still saturation cannot be maintained, then we provide through these types of non-rebreather masks. Why non-rebreather? Patient cannot rebreathe. How patient cannot rebreathe? We connect it. This is the universal port. So connect it through it. At first, we inflate the balloon, then it fixed with the patient. Then the balloon is filled with oxygen. That's why when a patient inhale, take 100% oxygen. When the patient exhale, the exhale air exit through this pore. And by this method, we can provide 15 liters of oxygen. 15 liters of oxygen through this non-rebreather masks. Okay. Then, if a patient come to you with severe hypoxia, don't delay with nasal cannula face mask. Immediately, you put a non-rebreather mask. Then gradually step down. And this is very much helpful for this patient, I think. And if a patient provided with 15 liter oxygen through this non-rebreather mask, so what should be the FiO2 for this patient? 15 into 4, 60, and environmental 21%. Overall 80 to 85% FiO2 we can achieve through these non-rebreather masks. Okay, if a patient in non-rebreather masks and admitted in COVID ICU, how he can take water or take food? We have another method to feed him, as because most of the patient remain conscious oriented in COVID-19 department, but their involvement is mostly lung involvement, and this conscious oriented patient can solely eat or drink. And if a patient want to eat, so should we take off this mask and give him food? The duration, the interval between this deoxygenation may lead to hypoxia for this patient. That's why we have another method That is the high flow nasal cannula system. High flow nasal cannula system. So why we put in high flow nasal cannula? High flow nasal cannula system is one type of important oxygen delivery system through which we can provide 100%, we can achieve 100% FiO2 through this high flow nasal cannula system. We can provide up to 80 liter pressure per minute through this high flow nasal cannula system, and also heat and humidified air can be provided to the patient. Okay, three important things we have to know in the high flow nasal cannula system. There are only three things in the high flow nasal cannula system. One is FiO2, second one is temperature, third one is flow. Only three things we should be remember. So we already know about FiO2. Through non-rebreather masks we provide up to we can achieve up to 80 to 85% FiO2. So when we whip out this masks and give him food, we can simply put this high flow nasal cannula to the patient and set a FiO2 in the machine 80% with low flow system with optimum temperature, and we give him food or he can take water or other drinks, and by this system there are no interval between deoxygenation, and after eating or drinking we can again put the non-rebreather mask, and by this process continuous oxygen administration can be done for a COVID-19 patient. Okay, if a patient have some difficulties of oxygenation, that is if he face difficulties with this mask and he is still hypoxic, we should switch to the high flow nasal cannula system. High flow nasal cannula system. So what is high flow nasal cannula system? High flow nasal cannula can be provide 100% FiO2. That is, we can achieve 100% FiO2 through the high flow nasal cannula system. So high flow nasal cannula system consists of, there is a oxygen, there is a humidified chamber that can provide with heat and humidified water, and we can set FiO2 up to 100% in this high flow nasal cannula system. We set the optimum temperature so that oxygen can be adjusted with the body temperature, and we can set flow up to 80 liters of, and there are some lines. This is the lines for oxygenation, and we can connect it through the central line, and after that we can achieve the 100% FiO2. Through non-invasive ventilation, 100% FiO2 is achieved through this high flow nasal cannula system, and we can also provide the patient hot and humidified air. So after providing 100% oxygen, we check the patient's saturation and pulse, respiratory rate, and other vitals. If the vitals are normal, we provide other medication and continuous oxygen administration for this patient. Okay. We try to avoid invasive ventilation for this COVID-19 patient, as there are bilaterally pulmonary infiltrate, that is development of ARDS in these types of cases. We try to avoid invasive method for this patient. That's why we provide high flow nasal cannula system for this patient, And through high flow nasal cannula system, a patient not only get oxygen from the source but also get a high flow that can prevent collapse of the alveolus, that can inflate lungs, that can increase surface area of the lungs, and hot and humidified air can easily provided through this high flow nasal cannula system. Okay, we can review 1 minute this appliance. That is, we discuss nasal cannula, face masks, non-rebreather masks, and high flow nasal cannula system. High flow and low flow nasal cannula system. What's the difference between high flow and low flow? In the low flow nasal cannula same, almost same. This is the nasal cannula and this is the nasal cannula. No difference at all, and this is the corrugated, so that hot, humidified and modified air we can be provided through this, and we can provide up to 6 liter oxygen through the types of nasal cannula, low flow nasal cannula. But in high flow nasal cannula we can provide up to 100% oxygen, that is we can achieve 100% FiO2 through this high flow nasal cannula system, and this is very much effective for COVID-19 patient, as by non-invasive method we can provide 100% oxygen through this. Okay, then we discuss about another things. We'd like to discuss about another things, that is, okay, before that I want to show a flow meter. This is the flow meter. This is the flow meter. Flow meter, there is the water in the chamber, and this is the oxygen connector. Universal port can be connected through this. This is the meter. We can increase up to 15 liter, and there is a marker and there is a pointer in it, and this port is connected to the central line like this. Okay, and this also can be set in the home settings, like in the cylinder of oxygen, in oxygen cylinder we can also fix it and provide oxygen up to 15 liters. In home settings we can provide oxygen up to 15 liters, but when the patient cross 5 to 6 liter, we should go for admission, because home management always cannot provide all types of management for COVID-19 patient. Okay, so we discuss about 3 types of masks, that is nasal cannula, face masks and non-rebreather masks. And we also know about the flow meter. We know some things about pulse oximeter. You can check pulse and oxygen saturation through the monitor, central monitor. You can check this pulse and oxygen. We switch on the monitor. Monitor is started. Would like to discuss about another appliance, non-invasive appliance that we can easily use for the patient. This is the monitor. This is the central monitor, and everything we can measure through this. This is the probe for pulses, pulse and oxygen saturation, through which we can check pulse and oxygen saturation through the central monitor, and we can get ready here. The blue line is indicate saturation, oxygen saturation, and pulse is 103 or 104. Okay, we close it. Okay. Then we like to discuss about another types of appliance, non-invasive appliance, that is CPAP and BiPAP. CPAP and BiPAP. This is the BiPAP machine. This is the BiPAP machine, and how we can connect it. There is this is the electric connector. We connect it. Okay, we connect it. This is the electric line. We connect it through this machine, and another simple things is there is a port for this, and we connect it to this. Then this is the max. This is the universal, not universal. There are a variety of sizes for this mask, and this mask is fit for the COVID-19 patient. Just fit like this and fix it like this. So this machine can generate pressure, not provide oxygen. So we have to connect oxygen line through this. Okay, so you can connect oxygen port, this is, and this fixed with this patient face and facial region, and it can generate pressure as well as provide oxygen by force. Okay, so what is the CPAP and what is the BiPAP? This is the machine that can provide positive airway pressure. Positive airway pressure, CPAP means continuous positive airway pressure. The patient can take oxygen through a positive pressure, and CPAP is most commonly used for type 1 respiratory failure, that is respiratory failure due to hypoxia, and most commonly used for sleep apnea patient. And BiPAP is the bilevel pressure, that is consists of EPAP and IPAP. EPAP and IPAP, these types of pressure, one pressure can maintain tidal volume, and another pressure can maintain PEEP, so that alveoli cannot collapse. The BiPAP most commonly used in case of COPD patient who retain carbon dioxide, and in case of left ventricular failure or any types of pulmonary edema, we can use BiPAP. So when we can understand a patient have come to you at type 2 respiratory failure. Okay, a patient come to you with disoriented and previous history of COPD, and after that you check him and proper investigation, you do an ABG, that is arterial blood gas analysis, and found that the partial pressure of oxygen is 50 millimeter of mercury and partial pressure of carbon dioxide is 70 millimeter of mercury, and this patient is have type 2 respiratory failure. Why is type 2 respiratory failure? Type 1 respiratory failure is only hypoxia. Type 2 respiratory failure consists of hypoxia plus hypercapnia. Hypoxia plus hypercapnia. So he retained carbon dioxide into his lungs. So we have to wash out this extra carbon dioxide. So how can we wash out this extra carbon dioxide through non-invasive method? Through this BiPAP machine. Then we put him the BiPAP machine, and after 2 hours we check another ABG. Then we found that partial pressure of oxygen is 80 millimeter of mercury, and partial pressure of carbon dioxide is 40 millimeter of mercury, and patient is alert, oriented, and feel better than before. We can provide CPAP through ventilator. We can provide CPAP for ventilator, and as a weaning method, we can use it in case of intubated patient. We can set FiO2, we can set other pressure in it. We can also bilevel pressure here, and inspirator pressure support, and we can set rate in the ventilator. Everything we can do in ventilator. But before going to the ventilator, we like to some non-invasive method for COVID-19 patient, as because COVID-19 weaning is very much difficult in case of ventilated patient, as severe bilaterally pulmonary infiltration occur. We cannot easily wean to these types of patient. Okay. Then advantage and disadvantage of this BiPAP and CPAP. Advantage is we can provide oxygen with pressure to the patient. We can correct oxygen through non-invasive method. But one of the disadvantages is patient cannot tolerate sometimes these types of marks in his mouth, and those patient has facial trauma, facial injury, burn. They cannot tolerate these types of patient, and we do not give them this CPAP or BiPAP. Go for intubation and go for mechanical ventilation through this ventilator. Okay. And this is the appliance we used for COVID-19 patient, and we avoid mechanical ventilation, as weaning is much more difficult in case of mechanical ventilation, and we try to non-invasive ventilation. All types of non-invasive ventilation we try to use in case of COVID-19 patient. Okay. Then after recovered, Mr. Jaman go to the home, and after 2 weeks of recovery, he come to us with some arthalgia, myalgia, oral ulcer, and feeling some sorts of breathlessness and weakness. That's why how can we suggest him to recover from this? We suggest him some oral antifungal medication that is act locally, that may be nystatin, that may be mycorrhizal gel, as the patient during COVID unit, during a stay in the COVID unit, he get steroid, dexamethasone, he get painkiller, he get lots of medication, he got inhaler, and oral thrush, oral candidiasis is common for these types of patient, and peptic ulcer disease is most common for these types of patient, as steroid was provided 7 to 10 days, and most importantly, these types of patient whose lung involved more than 50% or 75%, they come with fibrosis. After 2 weeks or after 1 month, we do an HRCT for this patient, and excuse me. Then we found that there are some fibrotic change of their lungs. Then we can give him some advice. First of all, we should provide him mental advice that you will be fit, you will be okay, because mental trauma is most common after COVID. Then arthralgia, myalgia, and oral ulcer, peptic ulcer disease, lung fibrosis. These are the common for the post-COVID patient, and most of the patient tell us that they have generalized weakness after 1 month, and we advise them breathing exercise, regular breathing exercise to strengthen their respiratory muscle. So how can they do breathing exercise? So today I'd like to discuss about a device that is the respiratory meter for respiratory exercise. How can? This is available in the market, in the pharmacy. There are 3 cylinder types: 600 cc, 900 cc, and 1200 cc. 3 color of ball. There is red, yellow, and blue. And there is inhalation exercise and exhalation exercise. And we connect it, corrugated, connect it through this. We connect, fixed it, excuse me, and then we inhale it. So gradually he can rise these 3 types of ball, and every time he do it 10 to 15 times and 3 times a day, and he should not do it frequently as respiratory muscle become fatigued. This is the inspiration. You can inspire and gradually increase this. And what is the expiration exercise? You should do like this and take it the mouth and blow out. And these types of exercise you can do in your home settings. And if this is not available, you can take a piece of paper like this and make a distance and blow and check if there is any movement of this paper, and gradually make a distance of this paper. And another types of breathing exercise is to sit and take deep breath. Hold it, exhale it. Breathe, hold, exhale it. And you can do it 10 to 15 times and 3 times in a day, and gradually increase this. After each time do it, we do it 10 to 15 times. After that, we make a cup and go for a prone position in the bed for 10 minutes. This is the one category of the breathing exercise. Prone position is most important for COVID-19 patient as it can correct VQ mismatch. I cannot, I don't want to go for details for VQ mismatch, but I want to tell about oxygen can redistribute throughout the lungs what we inhale from the environment or from the source. By proning, by left lateral position, oxygen can be delivered to the lungs and distribute through the lungs equally, and this can provide well balanced oxygen to the patient, and recovery rate after proning is better than those patients who 24 hours in supine position. So after COVID, after post-COVID recovery, we suggest patient, we give them mental support, we give them oral antifungal if they develop oral thrush or oral ulcer. We provide them PPI or other medication for peptic ulcer disease, and we advise them regular breathing exercise. Also, we do routine blood investigation and suggest them an chest X-ray or HRCT chest. So I have to close my session today. Hopefully everyone enjoy my session. Thank you very much.